So let's go through this a little bit. 65-year-old woman. She's not our classic patient. What do we see? She's had diabetes for 45 years, but she's incredibly well controlled with an A1C of 5.7. So there certainly could be a disconnect here with systemic control. But the chronicity is what's causing her problems. I first saw her as a second opinion in 2012. She did have CME at this point in both eyes, but we'll talk a little bit more about that. She was actually, at this point, not able to function because she, you can see on the second to bottom row there, she actually was count fingers in the right eye from a central retinal vein occlusion. And then she had a non-clearing VH in her only seeing eye. And she had been treated with anti-VEGF at this point and unable to do anything. She kept saying she was unable to drive to a Steelers game. No joke. It was, again, pretty horrible. So she was pseudophakic, standard stuff that we expect. I did a vitrectomy for her left eye in April of 2013. She did extremely well. And this is the treatment history just since I saw her. So she had 4 bevacizumab, 1 intravitreal triamcinolone, 4 dexamethasone implants, and as well as a focal laser. So what I'm going to do is just start at the last stage of the dexamethasone implant. So this is the classic appearance as we see. So 408 microns on the CFT, 20/40 vision. However, you would think, well, it's not so bad. But as a monocular patient, she would know to the day when her vision would go down. I mean, she could do it on clockwork when that Ozurdex implant would wear off. So 20/40 vision, pressure had always been good on the dexamethasone implant. So what I decided to do here, I gave her another dexamethasone.
And how often do you have to dose her?
Every 3 months on clockwork. She did very well with the Ozurdex implant for sure. I mean, she went down to 345, vision improved. Her pressure also was very stable. And at this point, we decided to watch her. Now, 3 months out, again, there's a bit of a lag here, right? So you can see her OCT does not look significantly worse, but her vision dropped significantly. Again, as a monocular patient, she knew immediately when that went down. So a slight bump in her CFT, pressure's still good. And at this point, I'd already talked to her about this implant that we had available. You know, I was kind of hesitant for a long time, and I'd like to get your opinions as well. But for me, I was hesitant to use the medication for a while because of finances. Honestly, the buy and bill prospect of it was a little concerning for me. But we worked through the whole process with her, got her benefits going, and she was approved. And so I said, let's try this. And this was September of 2015. So remember, she's post-vitrectomized eye already. We can also see she has an epiretinal membrane here too. So let's see what happens. 2 months out after Iluvien, tremendous response. Her vision is now down to 20/30, where she is baseline. CFT is improving. Pressure is great. I decided to watch her. Let's see what happens. So this is a year out now from that last slide. Her CFT is continuing to improve. Her vision is now still 20/30. She's had no other treatments at all. She's just had this Iluvien implant sitting in her eye. I actually do have one slide after this as well. This is February of 2017. But since I've moved to California, my sister actually saw her for me. She is a doctor. She's not just some random person. So she saw her in September of 2017. And she's doing even better. Her CFT is sub 300 at this point. Her vision is 20/30 plus. And at this point, she's been 2 years out, 24 months from the time that I did her injection, and she hadn't had a repeat medication at all. So it really has been an incredible option for a patient who's getting regular injections up until the point of me needing Iluvien. So you can see this is her treatment summary slide, just that one shot back 2015, and she's done incredibly well. And you can see what kind of strikes me about this is she's had this slow and steady improvement in her central foveal thickness throughout the whole time. So it's not like she had this initial dose and then she's just been stable. She's continuing to improve with each successive visit. Very effective in a post-vitrectomized eye. You could see that epiretinal membrane. You know, I personally do not peel patients at the time of non-clearing VH unless I know for sure they have an epiretinal membrane. But sometimes I think we get caught up in potentially what the tractional component of CME is. In my opinion, what I do is I try and treat them conservatively. If pharmacotherapy works, that's what I do. You guys do the same?
Yeah.
Yeah. So again, she, even with that epiretinal membrane, she would never let me touch her eye. And I mean, she's doing great, so there's no reason to for sure. And my last point here is, she did extremely well at 1 month. That certainly doesn't happen every time, but she's a patient, again, who obviously had a lot of inflammatory mediators as the cause of her edema, and she did great in just under a month. So I do temporize that now. I tell my patients it might be a little longer. Let's kind of wait and see how it does.
Indication: Iluvien, fluocinolone acetonide intravitreal implant, 0.19 milligrams, is indicated for the treatment of diabetic macular edema, DME, in patients who have been previously treated with a course of corticosteroids and did not have a clinically significant rise in intraocular pressure. Iluvien is contraindicated in patients with active or suspected ocular or periocular infections, including most viral diseases of the cornea and conjunctiva, including active epithelial herpes simplex keratitis, dendritic keratitis, vaccinia, varicella, mycobacterial infections, and fungal diseases. Iluvien is contraindicated in patients with glaucoma who have cup-to-disc ratios of greater than 0.8. Iluvien is contraindicated in patients with known hypersensitivity to any components of this product. Warnings and precautions. Intravitreal injections, including those with Iluvien, have been associated with endophthalmitis, eye inflammation, increased intraocular pressure, and retinal detachments. Patients should be monitored following the intravitreal injection. Use of corticosteroids, including Iluvien, may produce posterior subcapsular cataracts, increased intraocular pressure, and glaucoma. Use of corticosteroids may enhance the establishment of secondary ocular infections due to bacteria, fungi, or viruses. Corticosteroids are not recommended to be used in patients with a history of ocular herpes simplex because of the potential for reactivation of the viral infection. Patients in whom the posterior capsule of the lens is absent or has a tear are at risk of implant migration into the anterior chamber. Adverse reactions. In controlled studies, the most common adverse reactions reported were cataract development, Iluvien 82%, sham 50%, and intraocular pressure elevation of greater than or equal to 10 millimeters of mercury, Iluvien 34%, sham 10%.